Good morning, everyone, and welcome. Thank you for joining us for our live virtual NDA Engaged Community Education Seminar, where we are highlighting specialists in the Southwest area today. I'm Nicole Petrowski, and I am the Community Education Specialist for NDA, and we appreciate you joining us virtually so we can learn more about this seminar. MDA is committed to community education, and we believe in the power of bringing community together for opportunities to learn from specialists and having opportunities to connect with others. This event is part of the larger MDA Engage series with disease-specific symposia, community education seminars, and community webinars. Our community education seminars, which is what we are having today, are geared towards general neuromuscular diseases. While each event will feature regional specialists covering these topics, each event will also feature a specialty topic, which you can view on the screen. All these are the events that we have lined up for the remainder of 2020. And you can also see our last disease-specific symposia is our SMA symposia on November 14th. Some of you might remember the MDA telethon if you're a little bit older with Jerry Lewis. Well, we're excited to relaunch this legendary Jerry Lewis MDA telethon with Kevin Hart joining as our host. The telethon will be a 2-hour special airing globally on Saturday, October 24th at 8 p.m. Eastern. Hart will be joined by celebrity guests such as Jack Black, Eva Longoria, Michael B. Jordan, Jillian Mercado, Usain Bolt. And funds received from the telethon will support the work MDA does for the 43 neuromuscular diseases under our umbrella. To learn more about this big day, you can visit thetelethon.org. And we would not be able to put on educational programs without the support of our generous sponsors. So I would like to thank New Motion Foundation, Biogen, and Genentech for supporting this seminar. I do have just a few housekeeping items to go over before we begin today. We are recording today's event and we'll be posting it to the MDA website for on-demand viewing in a few weeks, and to ensure those who weren't able to view can watch it later. Please note all phone lines have been muted for all those who are in participation. And we will be having a Q&A session at the end of each presentation, so please utilize the Q&A icon to type in your questions. If you hover over the bottom of the screen, a tray of webinar icons will pop up, and you could click to host and send your questions. And we also encourage participants to communicate with others by utilizing the chat feature. And you can simply click on the chat icon at the bottom, and make sure you click to all panelists and attendees. The attendees is important because that's how you'll get to the other people who are watching. And you could type in your comment if you just want to say hi or where you're from, or if you have questions from others, please feel free to use that feature. And you'll notice on the agenda we have a few small breaks. I will be checking audio for our next presenter, so you will hear me speaking and the next presenter speaking. So I am aware of that. And you can also use that time to step away and get something to eat or get something to drink. And then finally, I will be sending out a brief survey afterwards. We'd like to receive your feedback to hear what you thought about today's seminar. We use that feedback to provide future educational events, and we like to use your feedback to do that. So with that, I am going to introduce our first presenter, Dr. Ratna Sanka. Her first experience in medicine started in the footsteps of her father, who is a neurosurgeon in India. And being a physician in a third world country was definitely a limited technology and access to care. So he had to work through many different difficult situations. So her interest in neurology and neuromuscular autonomic disorders was further bolstered in medical school and residency by her mentors. The lack of ability of rapidly evolving medical knowledge to change the course of a disease like ALS is clearly visible to her. And during the course of her work as a clinician and associate professor, she realized that practicing medicine involves more than just treating patients. She assumed the role of the clinic director to lead her clinic and provide efficient, timely care to all her patients in the current healthcare setting. They are developing innovative methods to train and use advanced practice providers to overcome the shortage of neurologists. And she realizes this is the beginning of her career, but she's very excited about the opportunities lying ahead and ready to face the challenges to become a great clinician, researcher, and leader of our community. Dr. Sanka, I love your compassion and focus. That's awesome. Thank you for being here today. I'll let you go ahead and share your presentation.
Thank you, Nicole. That was a very generous introduction. So let me make sure I have my PowerPoint. let me go. I think it went to the, let me think it, sorry, it started from the middle of it for some reason. Okay. Okay, again, thank you, Nicole and MDA, for giving me this opportunity. I do want to start off, again, my topic today is emerging treatments and research in the muscular dystrophy and related neuromuscular disorders. One of the associate professors at UT Health. Let's see, that does not want to, okay, does not want to go. Okay, so these are my disclosures. So what we're going to talk today is we're going to talk about the disease just really briefly and talk about available therapies and the treatments in the pipeline. The diseases that we're going to go through are Duchenne muscular dystrophy, limb-girdle muscular dystrophy, Charcot-Marie-Tooth disease, spinal muscular atrophy, myasthenia gravis, and also ALS or amyotrophic lateral sclerosis. So let's start off with Duchenne muscular dystrophy. This, as we know, is a life-threatening muscle disease that is very common. It affects 1 in 500 males that are born. It is genetically inherited. It is caused by a mutation in the dystrophin gene that is located on the X chromosome. The dystrophin is a very large human gene, and it's responsible for producing a protein called dystrophin that stabilizes the muscle membrane. So here, let me get the pointer. There we go. So here is a picture of ultrastructure of a muscle. So it's a microscopic picture that is of how muscle looks. This is your muscle membrane, and this part is your dystrophin protein, and it kind of attaches to the muscle membrane with a lot of other proteins, and it stabilizes the muscle membrane. When you look at the actual, the dystrophin gene, it is made up of 79 smaller particles called exons, or and the mutations in these exons are responsible for the actual disease. So let me go back to, I think I need to remove the pointer to advance. I'm sorry for that, technology issues. The Duchenne muscular dystrophy, when we look at the genetic aspect of it, 80% of it is caused by deletions or absence of some of these exons, and 43 to 55 are the most common exons where we see mutations, with 14% affecting the exon 51 and going to 7% with exon 44. 10% is where we have a nonsense mutation. The exon is present, but it's mutated, and it causes a premature termination. So the protein that is produced is not an efficient, and it's a smaller protein. The treatment of these conditions has been so far twofold. So one, when we have the Duchenne muscular dystrophy, because of the protein being not the normal protein, there is muscle destruction and there is inflammation in the muscle. So the initial treatments that came up were anti-inflammatory. So the most common one that we have used for a long time is prednisone, or it's a corticosteroid. There's also another pro-corticosteroid that has been approved. It's called deflazacort or Emflaza, and basically these are not changing the cause or the pathology of the disease, but they are reducing the inflammation in the muscle, and sometimes the inflammation can cause secondary damage to the muscle, so they're trying to prevent that. Both these drugs have been shown to slow the disease down, prolong the child's ability to walk and use their upper limb with different activities. And sometimes they've also shown to slow down the disease effects on breathing. But lately, it's been more focused focused, the treatments have been more focused on the genetic aspect of the disease. As we spoke about, there is exons that can be deleted or missing in some of these patients. So they are using a different technology called exon skipping. And we have 3 medications that have been approved already for this. One for exon 51 skipping, and the others for exon 53 skipping. These are called eteplirsen, golodirsen, and viltolersen. Again, there are all these tongue twisters to make sure I had my morning coffee. So the ongoing studies, there are more ongoing studies on exon skipping medications that are going to specifically look at people who have deletions in exon 45 and 51. There's also an ongoing study that that is looking at a stop codon read-through. It's called ataluren. These are for the nonsense mutations, as we spoke about. There are studies that are looking at antifibrotics, meaning agents that reduce the scar tissue in the muscle. One of the things that there is a study that's in the very late phases is idasalinexant. It inhibits what we call NF-kappa B, which is a pathway that causes muscle breakdown. And by inhibiting that pathway, there is improvement in repair of the muscle. And the exciting area of these muscular dystrophy treatments is also gene transfers using what we call AAV. It's a viral vector, and also some gene editing pathways using CRISPR. We're going to talk a little bit more about each of these. I'm going to start with these exon skipping therapies. Go back to the pointer. Okay, so normally in Duchenne muscular dystrophy, as we said, there are different exons, and in somebody, this is a patient who has, if you see, he has missing exons 45 to 50. And what this causes is a production of a smaller protein because the translation or the way the protein is produced just stops at 44. It doesn't go all the way to the end. So the smaller protein is produced. This is not as functional, causing muscle damage. These exons skipping therapies, what they are called are antisense oligonucleotides, or AON. What they do is they bind to a part of the exon or the mRNA or the gene, and what it does is it causes the protein to read through this abnormality and produce a partially dysfunctional. It's not a completely normal protein, but a functional protein, dystrophin, and this improves the muscle function. Right now, what they have are called there are different formulations that need to be administered frequently, every 2 to 3 weeks, and sometimes have been known to have poor penetration into the heart muscle. Duchenne affects cardiac muscles too, and they're trying to look at newer molecules. These are called PPMOs that have better ability to enter your heart and also can stay longer in your system. One of the medications that they are trying is called SRP 5051. Let me take this off. So the next modality that we are that is in the late stages of trials is called read-through of a premature stop codon. So this is a picture that shows the dystrophin being produced by mRNA going through your the dystrophin gene. But sometimes they have these this is a normal protein where at the end of the gene there is what we call a stop signal for the protein to stop being produced. But in patients who have this stop nonsense mutation, it happens earlier in the gene, producing a smaller non-functional dystrophin. And what these medications do is they bridge that gap and let the protein, a bigger functional protein, being produced. So these are called read-throughs or therapies. And one of the things that we are looking at is ataluren. It has shown benefit in a subset of population in these phase 3 trials. It has already been approved in Europe in 2014 for children about 2 years, and in Brazil recently in 2019. There is a ongoing study in US, and it's going to be we're going to expect results soon. I think one of the things that FDA pointed out was that some of the studies didn't really look at the amount of dystrophin protein that is created in the children who were treated with it. So they're looking at some of that to show that it is efficacious. So that's we're eagerly waiting for the results of that trial. The other pathway is the antifibrotics, as we talked about. Catabasis is doing this study on idasalinexant. Again, this inhibits the pathway. It's called NF-kappa B pathway. This pathway causes muscle breakdown and prevents muscle repair. So by inhibiting this pathway, the medication preserves the muscle function and slows the progression of the disease. It has, in the phase 1 and 2 trials, they have shown really good results. And I think the phase 3 trial is they're looking at the data that they've already collected, and we're waiting for results. Hopefully by the end of this year, we will see results of this trial. The more exciting part for everybody is the gene therapy. As I said, dystrophin is a big gene, so it's really hard to transfer the gene into the children who have an abnormal gene. So what they are using is using a truncated or a smaller but yet functional part of the gene, and they are using these viruses called AAV virus, and they are using this virus to inject the gene into the children with Duchenne muscular dystrophy. It can be injected directly into the muscle or into the blood, and what it does is production of this smaller but yet functional dystrophin protein. So this is a patient who has no dystrophin because of the abnormality in a gene, but when the virus injects this gene, the microdystrophin, which is the gene that they use with these AAV vectors, it gets into the patient's cells and produces a functional dystrophin. And recently there was data from a microdystrophin AAV study that showed really functional improvement in 4 boys who got this medication, and also showed that it was tolerable and safe. So I think we're going to see a bigger trial starting soon using these gene therapies. The last but not the least, there is an editing therapy. It's called CRISPR, where they inject a part of a molecule, which is a guide, into the cell, and it binds to the dystrophin gene right before where there is an abnormality, and they inject another part of a DNA, so to bridge that gap or edit that abnormal mutation that's there, to be able to produce a good functional dystrophin. So these studies are still in kind of the earlier phases. So it's almost like it's an editing that is done internally in the gene part of the patient's molecules and the cells. So this is, again, as I said, it's in the early phases, and we are looking forward to more details about this way of treatments. So a lot of treatment trials going on with dystrophin in different pathways. So it's starting from inflammation to fibrosis to the gene. There may be, I think, talks about combination trials where you can add 2 different mechanisms of action and use it to treat the children to hopefully prevent the progression and improve the muscle function and kind of help with this devastating disease. So that's about the Duchenne muscular dystrophy. Moving on to another very similar field, it's called limb-girdle muscular dystrophy. These are also very similar to Duchenne. They're inherited muscle disorders with different genetic bases. They're much rarer, though, than the Duchenne. As we say, it's 2 in 100,000 population, and they only compose 9% of the muscular dystrophy. But there are multiple different subtypes of them, at least 30 different subtypes. And there's a lot we know about the gene abnormality in them. So these are being tried for also the gene transfers using AAV vector adeno-associated virus being used to transfer these single genes into the patients with the muscular dystrophies. So recently just some data on 2E, limb-girdle muscular dystrophy 2E, where there is a beta-sarcoglycan, that's the protein that is abnormal, and the data showed really positive results with tolerability and functional improvement. So exciting time again for this rare disorder. They are looking at this kind of AAV transfers for other muscular dystrophies like 2A, which is abnormality in calpain, 2L, which is abnormality in this protein called anoctamin, 2B, dysferlin, and the other sarcoglycans, alpha and gamma sarcoglycans. So a lot of gene therapy trials that are looking at it, still in early phases. Hopefully more information to come soon on these. So moving on to the next common disorder that we see is spinal muscular atrophy. Again, this is another hereditary neuromuscular disorder that causes weakness, both of your limbs and your respiratory muscles. The abnormality here is a mutation that causes loss of this protein called survival motor neuron. And the survival motor neuron actually protects your motor neurons. These are the cells in your spinal cord that control your muscles. So when you lose those, you cause muscle loss and weakness. It's very common with the incidence of 1 in 11,000. I think this has seen the most exciting improvements in treatments. In 2016, a medication called nusinersen was approved, or Spinraza, and the trials showed improvement in motor milestones, and they reduced the need for ventilation or breathing support, even for children and infants with this condition. And recently in May, another medication called risdiplam or Evrysdi got approved. Nusinersen is a medication that needs to be given into your spinal fluid, so we need to, but risdiplam is an oral medication. And these both medications work by increasing this, what we call SMN2. So normally our body has two survival motor neuron proteins, 1 and 2. 1 makes the majority of the protein that protects your motor neurons, and 2 makes maybe 10% of a stable protein. So these two medications, nusinersen and risdiplam, what they do is they increase production of a stable SMN2 related protein that protects the motor neurons and improves the survival of the motor neurons, thus causing improvement in the muscle function without progression of weakness. And sometimes these children, infants who get it, they actually have a normal milestone and can walk. When in infantile SMA, children do not even sit or walk. So we've seen tremendous improvements in this condition. But the most exciting part was the gene therapy. It was the first gene therapy that we have seen in neurology. It has a long name, on a Semna gene, ebaparvovec, or we call it Zolgensma. So what this does is it uses a virus called, again, the same adeno-associated viral capsid to deliver a wild type of this gene into the children with SMA. It's a one-time injection, and this gene goes into the cells of these children and makes them produce a normal SMN protein and protect their their motor neurons. It was approved in May 2019 in children under 2 years of age, and even with patients with children who are pre-symptomatic but have a known mutation. So there's a push, hopefully, for early diagnosis, because once symptoms start, the recovery is not as much. The earlier the treatment, the better it is. So there are some states that are doing newborn screening for SMA to help identify these children and start them on therapy sooner than later. So that is SMA. There are other ways that they're looking at therapies to help with SMA. These are improving your muscle function. There's a medication called reldesemtiv. It is a small molecule that improves your muscle contraction by activating one of the components of the muscle called troponin. There's also myostatin inhibitors. It's called SRK-015, which promotes the muscle growth and improves muscle force. So again, trials underway on other ways to help with the muscle function, not at the gene level, but on the cell or the muscle level of these patients. Again, moving on to the next part, which is a Charcot-Marie-Tooth disease. This is a neuropathy. It affects the nerves, and it's inherited, and it can vary from 1 in 1,500 to 10,000 patients. There are different varieties of CMT or Charcot-Marie-Tooth disease. 1A is probably the most common type, affecting 70%. And the mutation in this causes extra protein called PMP22, which causes a damage to the myelin. There were some other therapies that were tried. They tried vitamin C supplements, which did not show enough benefit. But recently, a trial of a combination of some of the known medications that we use for other conditions. It was a combination of baclofen and naltrexone and sorbitol showed that it was safe and tolerable. And it, in a phase 2 trial, a smaller trial, it did show some functional improvements. So we are looking to see some of the phase 3 trial results. There are multiple other medications that are being tried. One of it is modifies this neurotransmitter called GABA, and it thus reduces this extra PMP22 protein. It's called ADX71441. There's another medication that stabilizes these tubules. These microtubules can be affected in neuropathy, especially the CMT2, which is a different exonal variant. It's called ricolinostat. They're actually looking at this medication even in chemo-induced neuropathies, because some of the chemo-induced neuropathy affects these part of the nerves called microtubules. There's another medication that they're looking at. It's called Cephin-1, which controls the myelin, which is the coating of your nerves, and they're looking at that in CMT1A and 1B. So a lot of treatment trials in like early phases, but unfortunately, for this condition, we don't have a treatment that is active or shown to be helpful, but hopefully soon we will see some new medications that are approved for treatment of these conditions. So moving on, so far we have addressed some of the hereditary or genetic disorders of your neuromuscular system, but myasthenia is actually an acquired, or it's an autoimmune kind of autoimmune therapy, autoimmune condition where it blocks the transmission between the nerve and the muscle. The nerve is fine, the muscle is fine, but the transmission does not go through because of blockage of the signals with antibodies. There are some available treatments that we're already using, which is steroids, medications that are used for transplant rejection, like mycophenolate or azathioprine. But one of the newer medications that was approved is called eculizumab or Solaris. So this actually blocks this, what we call a complement, which causes damage to the muscle part of the pathway. It's called the motor end plate destruction. So it's been approved for treatment of myasthenia. So it's severe. It's in the market right now. There are other treatments that use the same pathway that are in the works, like zilucoplan and ravulizumab. Treatment trials are underway. There's another kind of pathway that they're looking at. It's called neonatal FC receptor blockers. So normally when there is myasthenia, you have these antibodies, and these antibodies are recycled by your body, so they cause more antibodies. So these medications, what they do is they prevent the recycling and they reduce the antibody load, and thus helping your muscles to recover and not cause as much damage by these antibody-mediated destruction. So it's recent trial on this medication called efgartigimod has shown help in patients with myasthenia. So we're waiting a full release of the results soon, and hopefully approval shortly. There are other medications using this same pathway called nipocalimab and rozanolixizumab. I think I messed that word up. So, so lots of medications, if you see under therapies with myasthenia. Actually, the eculizumab was approved, but you can see different medications being tried, and there is for myasthenia. So this is actually a good cartoon to remember. This is where your muscle, this is part of your muscle, and this is the part between the nerve and the muscle, and these are your acetylcholine receptors. The antibody, as shown in this inverted Y, binds to these acetylcholine receptors, and then there is complement, which is this red molecule. Actually, complement causes destruction, and these red molecules are complement inhibitors that can protect your muscle membrane. So these complement inhibitors are eculizumab and ravulizumab and zilucoplan. But if you see, these antibodies are being recycled by your body, and these FcRn inhibitors are preventing the recycle, and those are the other treatments that are in works to see if they're helpful, and some of them have been shown to be helpful in early phases of the trials. This is going in ahead on the pathway. This is where the antibodies are being produced. So they're looking at these CAR T cells therapies, and then B cells are part of your lymphocytes that can increase the destruction of the muscle membrane. So they're looking at inhibitors of B cells too. So a lot of medications that are being tried to help myasthenia. So moving ahead, and I see some of the Q&A questions coming up, so I'll probably get to them right after. This is, I think, probably the last slide I have. Talking about ALS, again, very progressive disorder that can cause loss of the motor neurons, and affecting every part of your body, muscles of your limbs, breathing, speech, swallowing. It's a very aggressive disease that we so far have 2 treatments that are available, riluzole, and which was approved in 1995, which has been shown to delay the progression and reduce the mortality of this very devastating disease. Recently, there was another medication a few years ago that was approved. It's called edaravone or Radicava, which is shown to inhibit the destruction of these motor neurons and reduce the worsening of the ALS. They use this functional rating scale that looks at every part of your muscle function, and it has shown to be slow it down. There was another medication that recently showed really good benefits in the Centaur trial, which is a combination of sodium phenylbutyrate and taurursodiol. So this trial has shown in recent data that showed really help improved function or slowing of the decline of the function. So we're waiting for more details on that study. There are also other medications that are being looked at, stem cell therapies, a therapy called tirasemtiv. And I think the key newer trials, they're looking at these combination drug trials, which are called platform trials, where different pharmaceutical companies come together to try different medications in the same trial. So there are like 3 in the Healy trial, they're looking at 3 different medications. They have come up with this plan because it shows that it's quicker, we can get more patients, and it's not as expensive to do some of these trials. So looking at it in this way can help us get to more medications being tried in a shorter period of time, especially in condition like ALS, where we've seen more trials than medications being approved. So it's been really exciting time in the field of neuromuscular disorders. Many new therapies that have been approved and are in the pipeline. We actually saw the approval of a first gene therapy for SMA. So again, this is a picture of some of the approvals, and you see the neurology number of medications that were approved in 2019 is almost double the average from 2014 to 2018, and we're next only to oncology in the number of medications that have been approved. So this is all possible because of all the effort by patient support groups and MDA and a lot of other MDA sponsors who have been very helpful in pushing a lot of these new innovative treatments, and just really exciting time for patients and providers like me to see that we can offer treatments to these devastating diseases. So that is my presentation, and I am open to questions. Let me stop sharing. And
Thank you, Dr. Sanka. We do have a question that popped in. How likely is it for someone to develop type 2 diabetes from prolonged use of prednisone? And I think a lot of our neuromuscular patients take a lot of steroids, and I think that's a huge question. That are, what are the severe side effects of using steroids for a long time?
So I think it's the steroids are used in 2 different modalities. One in a younger population like the Duchenne. We've seen more like weight gain, bone loss, and cataracts as one of the major complication than diabetes, because we don't prolong the use in Duchenne and muscular dystrophy where we use the prednisone. The therapy will be stopped when they unfortunately lose their ambulation, because it hasn't been shown to help once they are not ambulatory. So at that point, weaning it off is what we do. So not as common as in the adult population, the diabetes. In the adults who we have them on steroids for myasthenia or other autoimmune diseases, we have seen development of diabetes, either because they have an underlying tendency and this just pushed them over the edge, or because they needed high dose steroids that they do kind of develop more high sugars and more diabetes from there. But there is some underlying tendency in the population to make them have the diabetes too.
It's interesting. How is gene therapy administered?
There are 2 ways that they're doing it in different disorders. It can be injected into the muscle, but then if you cannot really inject into every muscle in your body, so that the trials are doing muscle, but the one that is approved for SMA, it's an intravenous, so it is injected into the vein just once, and then the virus vector kind of spreads all over your body and kind of gets into each cell to be able to produce that protein that the person is lacking.
Okay. This person typed in, I have a 47-year-old daughter diagnosed with myotonic MMD. I'm assuming that's myotonic. You covered the other dystrophies, but not myotonic muscle disease. She was diagnosed 19 years ago, and we have never been advised for any medications for her. Why are there no therapies for myotonic dystrophy?
I think, again, I'm sorry, I couldn't cover everything. We were trying to cover some of the ones that are being, so myotonic dystrophy, it's been, not on the forefront compared to the Duchenne and Duchenne muscular dystrophy. So there are very, very early phase trials that are looking at different treatments, but we don't have any trial in humans yet that is looking at treatments. So again, I may be wrong. I usually advise, not that I've seen in the last 6 months come up. There is a clinical trials. I always ask patients to go to this website called clinicaltrials.gov. I can put it in the chat box, the link to the trial, and always it's good to look into that and what therapies that they are. And sometimes, we may miss it because it's not being offered in our region. But if there is a family member who reaches out to us saying, okay, this is a trial that I saw. Do you think we can be part of it? We have asked our patients to reach out to us if they see anything that they feel like is helpful, going into the clinicaltrials.gov website. And then we have reached out to the sponsor or to the site that is closest to us to get more information for the individual patients. So at this point, we don't have anything ongoing, but that doesn't mean there's so many trials going on. It's just hard to keep up. And, I think if you reach out to your provider, they will be happy to help you. And looking at the clinicaltrials.gov website is a very good resource.
I know you had talked about CMT, and 1A has become, or 1A is the more prevalent diagnoses. And I believe you talked about it, but could you just reiterate, are there current medications or treatments for CMT 1A?
So again, right now we do not have any treatment that are available. So what we do is treat, for the using devices, orthotics, and symptom management is all what we do. So I think it's trials are ongoing that we're waiting for, but no, the one treatment that they've shown preliminary benefit was a combination with baclofen, naltrexone, and the ursodiol. So we're waiting some larger trial data or a bigger trial information on that medication combination.
Okay. Will SMA treatments benefit ALS studies since they are both motor neuron diseases?
I'm assuming they're talking about SMA and ALS.
Yes.
Okay.
Will SMA treatments benefit ALS studies?
So we have not seen the survival motor neuron abnormalities. It's a different pathways of destruction of the motor neuron in ALS with activation of your microglia and some other neurodegenerative pathways. So they have not seen a commonality in the pathways. So I think some of the muscle ones that I spoke about that improve your the troponin, those are being tried, but not the gene-specific treatments for SMA because the genetic part of it is different. But the muscle improvement part that are being used are being tried in both treatments or both conditions.
And will the SMA gene therapy ever become available for adults?
So far, I have not heard anything in that realm, especially because what we see is that once there is muscle atrophy, if there is significant atrophy or muscle loss, they may not be as effective. Even you have to prevent the damage to the motor neurons. These are not really creating new motor neurons. So once there is loss of some of these motor neurons in adults, the gene therapy is not effective because it only prevents the loss of them. So at this point, I want to say no, but is there going to be something new later? They'll find a way. We're always hopeful. We didn't think about even these gene therapies 10, 15, or 20 years ago, and now we're seeing so many of them. So things keep changing, and we're hoping for better therapies. But at this point, no.
Do you have any interest or experience with VCP disease?
It's a rare condition. I am gonna say, I've heard about it, read about it, but I don't have any patients with it. So,
And we just kind of highlighted on some of the most common types of muscular dystrophies and autoimmune, but is there anything on the horizon for Emery-Dreifuss?
um, I want to say I have not seen anything in a larger clinical trial. There are
Hmm.
probably something really phase 1 early trials that but nothing is a phase 2 or phase 3 that I would look into clinical trials. That is my resource guide every
Hmm.
time I have a patient coming in with any of these muscular dystrophies. I go to that website to see what medication trials are available, and to be able to provide to the families. There are so many of them, and there is so much improvement and their research going into each one of them. So yeah,
And
I apologize if I don't keep
it's
up with
being
all of them.
it's being some of these treatments are moving at light speed. I also want to let folks know that on our MDA website, we also have a clinical finder tool that you can also use that to locate for clinical trials. And is there anything new on limb girdle 2.1? It's 2.1,
2i.
2i. So sorry.
Again, not that I have seen, the ones that we are looking at, the gene therapies were the ones that I put
Mhm.
in there, but maybe, again, not that I have seen. I will have to look into to see what is available.
Okay. There's a lot out there. Thank you, everyone, for all your questions. And Dr. Sanka, thank you very much for your presentation. We learned a lot. I appreciate you being here this Saturday.
Thank you.